At the end of this, I am going to tie it all up with a case example. It was my own. And this should show you, really give you a cool feel for how complex this stuff all is, and why you need to be really strong as a clinician when dealing with this stuff, both in terms of diagnosis, workup, and treatment, both acutely and in the long term. Otherwise, you are going to cause some great damage. Hey everybody, welcome back to the channel. Today's topic's gonna be generated around the question, is methamphetamine psychosis the same thing as agitated delirium or excited delirium syndrome, and does it kill? You may be wondering why we are going back to psychosis. We have two other videos on methamphetamine psychosis. Number one, it is an important topic and cause for a lot of social and psychiatric and physical consequences from methamphetamine abuse. Okay. Number two, the disorder itself, not dealing with it in terms of stimulant abuse or methamphetamine abuse, lends itself heavily to long-term recovery or lack thereof. Number three, it is just simply very interesting to understand this topic. You can come at psychosis from a historical perspective. You can come at it discussing it through personality disorders. For example, cluster A and B are very laden with this concept, and also the concept of neurosis, which we can do at another time. For many reasons, it's very important, and that's we've decided to go back and touch on it, especially since we just finished our series on flocka or synthetic stimulants, and the fact that these are associated with a lot of psychiatric issues. For those of you new to the channel, I'm Dr. B with Addiction Recovery. We are a nonprofit endeavor aimed at discussing all things substance abuse to hopefully give everybody kind of a formal understanding of this stuff and take some of the mystery away from it. If you do like our content, please like and subscribe. If you are even more inclined, please go ahead. We do have a Patreon and a channel membership account. And those of you that have already contributed, we really want to thank you. Also, let me thank the coach and his wife, Addicts to Athlete. They sent me this wonderful, beautiful shirt, and they also sent me a really touching card. They're great, great people, and they are working very hard to bring people to recovery through what they know, which is exercise or athletics or physical rehabilitation. Now, I want to say something about that, as I have dealt with that myself over the last few months. And it is a really, really important part of everybody's recovery wherever you're at. Let's get started on the topic, okay? Is methamphetamine psychosis the same thing as agitated or excited delirium? And which one, or does it kill? Can it kill? On this round, we're going to approach this, like I said, a little bit more in a formal way. So to answer this question, we need to get some grasp of what is psychosis. And then from there, we'll go to meth psychosis, then agitated, excited, delirium, and so forth. So when you ask what is psychosis, we can approach this in the way that I usually like, historical, but we're going to put that to the side. You can come at it a couple of different ways as well. You can talk about it in terms of, interestingly, personality disorders. Cluster A and B are very intimately linked to this concept of psychosis. Schizoidal psychosis, schizophrenia. Type A and B are very intimately linked to schizophrenia and psychosis, especially type A when you talk about schizoidal and you're talking about schizophrenia. We can also introduce the concept of neurosis. We're going to put those to the side, give you a very clean, undressed, formal construct of psychosis. In the current conceptual model of this pathological entity, psychosis, okay? American Psychiatric Association and World Health Organization define psychosis very narrowly, without all the dressing. Essentially, what it is hallucinations without insight into the fact that they are hallucinations, delusions, okay, or both, okay? And very linked to these two things, and very central to these two concepts, given the current classification and diagnosis, is the idea of reality testing being a failed attempt. So let's look at hallucinations first, okay? How do we define hallucinations, okay? Okay, let's define hallucinations first. What are hallucinations, okay? They are sensory perceptions. Remember your five senses, taste, touch, see. There are sensory hallucinations, okay? In the absence of corresponding external stimuli that can be described in terms of that particular sensory domain, okay? Which means there's no sounds that you're hearing, but you think you're hearing it, okay? There is no object to be seen, but you think you are seeing it, okay? So it is the absence of the corresponding external stimuli, okay? And these can occur with or without insight. And I'll think of a couple of examples here in migraines, migraine aura, okay? The person with the migraine knows that they're not there, okay? Ringing in the ear maybe for some reason or another, okay? The person is very well aware that no one's ringing anything out there, and it could have happened for a whole bunch of reasons. Smell, okay? Taste, okay? Olfactory, gustatory. A person can have, after a flu, a cold, a viral infection, they might smell these things, taste these things, but they know it's not real, okay? So that's with insight, okay? So key to this hallucination is the fact that there's no insight, according to this definition, current classification. Okay, so what are delusions? They are basically fixed, false beliefs about oneself or the external world, okay? And they are based on incorrect, false inferences about reality, okay? And they are maintained very firmly, regardless of the degree and extent of evidence presented to the person to show that their belief is false. That is a delusion. And so you can see there is an impairment of reality testing in both of those. For whatever reason, they can't get to it. Now, there's a lot of great, cool examples of all of these, and these also have additional modifiers on them, right? Paranoid, okay, paranoid delusions, hearing voices, telling persecutory auditory hallucinations. We're going to skip all that for now and just really hone in on the meth one for a second, but understand that there's a lot of other things here. In addition, there's a lot of cognitive sort of dysfunctions that are associated with the concept of psychosis, but this is the basics of what psychosis is. Delusions, fixed beliefs that the person maintains vigorously, regardless of the evidence presented to them. Hallucinations, five senses, right? There's no external stimuli of the senses, and the person does not have insight into the fact that these are not real, okay? Well, we could talk about this forever. It's very cool and interesting, but let's move on. Now, you have the basics for what psychosis is. So is it a disease? Is it a symptom? What's the deal? And it's really a symptom, but it's very intimately tied to a particular disease, psychiatric illness, and it's schizophrenia, right? And it's really better formulated as schizophrenia spectrum disorders, okay? And it is the defining feature, okay, of schizophrenia spectrum of disorders, and in that case it would be called primary psychosis, and it's a common but variable feature in many other disorders, some of them psychiatric, like mood disorders. Severe depression can come with hallucinations, delusions even. Medical illnesses, you might have a tumor somewhere in your brain that's pressing on let's say your olfactory bulb and you're smelling things. So medical issues, other psychiatric presentations can have them. Substance use disorder, okay, can have it. And it's also a very common feature of many neurological development, okay, neurodevelopment mostly, and degenerative neurological disorders and medical conditions. For example, at this time, I'll give you a really far field one. At this time, they're even considering this thing called autoimmune psychosis, right? Which is kind of crazy. But autoimmune psychosis, secondary to immune dysfunction. Okay, all right. In the case when it's not primary psychosis, for all of those other things, it's secondary psychosis. Therefore, for methamphetamine-induced psychosis, right, that would be secondary psychosis, all right? And that's sort of really important, both in terms of acute treatment and long-term treatment. So it's kind of key here. So that's something I think you should know, okay, about this, okay? So someone's just not nut job, okay, or someone's just not crazy. It's very important to get to the bottom of this. So how do you tell methamphetamine psychosis apart from primary psychosis, schizophrenia, or other psychotic-inducing clinical conditions? And this is important, okay? Now we can talk about potentially, okay, in methamphetamine psychosis, they always have this additional feature to it. And we could say that, for example, we could say agitation or even violence, but it wouldn't be true. And it's not enough to capture it. And here is, from a clinical perspective, the clinician, here's where a astute and a skilled clinician can really utilize comfortably their skills without even attaching a final diagnosis and still proceed with treatment. And in clinical medicine, we call it history of present illness. Essentially, the history of this event and all of the things that come with that, okay? And it really has to do, quite a bit of it is going to be with the temporal relationship of the onset of psychosis and how much meth they've taken and so forth, okay? So basically, you have this patient, and let's make it very difficult. You know nothing about them. And you have to figure out what they took, when they took it, when did the symptoms come on, has he ever had them before? And this may be difficult at that time, right? At the time of presentation. And so this is part of that history of present illness is family, friends, loved ones, whoever they're around. And in addition to that, you want to use laboratory testing, like urine toxicology. Now, if you do use urine toxicology, keep in mind, because this stuff is so ubiquitous and everyone uses it thinking it means something, it doesn't. A person could be weeks or months away from methamphetamine use, and they could be in psychosis that waxes and wanes in severity, and their urine would be negative, right? So you see, it takes some skill, some clinical skill and judgment to be able to discern, okay, what the primary cause of the psychosis is, okay? And again, this is very important in methamphetamine or substance or stimulant-induced psychosis, because it really matters with treatment of the primary issue here, namely methamphetamine or synthetic stimulant causing the psychosis and their addiction to it and the psychosis. All right. Number two, the other issue here is it gets even more complicated. What if this person was sort of heading for their first psychotic break, and they do have a history of schizophrenia in the family, and they were kind of edging towards that at this time, and it all kind of coincided. So you see, it's if you're going to do this right as a clinician, you really have to be thinking of all kinds of things. What if they already had psychosis and from primary disease of schizophrenia or any other disease, and they're also doing methamphetamines now, okay? It's really the chicken and egg kind of a thing, but you can get enough, and if you don't, as a clinician, you can still initiate stabilizing treatment and sort all of this out later. In terms of how this looks, oftentimes they're agitated, they may be violent. The question for you, the loved ones, and the patient becomes, when do I take him to the hospital? When is there an issue? When can I take him just to the doctor, and so forth? And that's a simple one. And it's not what, if you're uncomfortable, you need to call first responders. Technically, going to the hospital on this issue is if the person is a danger to themselves, they can't take care of themselves without, or they can't plan anything, or they're a danger to others. That should be a simple trigger. But let me make it simple. If you're uncomfortable, call. I want to point something else out, because again, this becomes important when we discuss long-term recovery from the substances that we are discussing. Oftentimes, families see this, or the person has been dealing with this, but we can just call it they're having auditory hallucinations and they're hiding it, okay? And the fact that you let this go on and get worse with continued methamphetamine use or stimulant use and abuse is going to really hinder long-term recovery of methamphetamine addiction or substance abuse, whatever the substance may be. As far as treatment for this case, again, if they're highly agitated and they need to go to the hospital, or if anything you feel uncomfortable with, you should call. At that point, and they go in, the acute treatment is going to be either you try and talk the person down, put them in a calm room and so forth, and let them sleep it off, or some benzodiazepines, or some antipsychotics acutely, sleep, hydration, make sure they're not in kidney failure, and that would be the acute treatment. Now, why is this such a big deal? Why do I think it's such a big deal? I think it's a big deal because up to 40 or 50% methamphetamine users will experience psychosis at some point in their lifetime, okay? And unless if this issue is addressed and continued use occurs, it's very possible that the psychosis can get worse. Also, there's a subset in this group that will have long-term psychosis, and many times it's not treated, okay? And finally, we clearly know, okay, at least for methamphetamines, that we don't have a first-line pharmacotherapy intervention like we do for opiate use, okay? And the most important thing is psychosocial intervention, okay? And along with this psychosis and methamphetamine use comes a lot of things: irritability, anxiety, mood disturbances, sleep disturbances. These are all prominent psychiatric symptoms common with methamphetamine users, and they will impose and the impulsive behavior and all the risks associated with it. And we know that once someone is getting psychosocial intervention, the episode or the likelihood of an episode or episodes of psychosis goes down, and when the psychosis comes, treatment is even more difficult. And B, their long-term recovery is going to be a lot more likely and sooner than if this issue is not addressed. Okay? Now, I don't concentrate too much on the time of onset, time of this stuff going away, using these things to figure out if it's methamphetamine or otherwise, because I don't find it that helpful, but that data is there to some extent as well. The key thing here is that this stuff needs to be addressed for long-term recovery, and the quicker somebody gets into psychosocial intervention, the less likely it is that they will be going into psychosis and making things difficult, and even if they've had an episode of psychosis. Number two, having that psychosis is an additional burden on that person's capacity to engage in occupational and social endeavors that are extremely costly to society, that patient, as well as their ability to get well. And with that psychosis, does psychosis kill itself? Not necessarily, except if it puts them in a dangerous situation of impulsive behavior, secondary diseases, continued methamphetamine use, and so forth. But it would be cause for a lot of what we would call morbidity that can lead to mortality, a lot of illness that can lead to death. That's pretty much methamphetamine psychosis in its simplest way. And now you can guess it's quite different than agitated delirium or excited delirium syndrome, and it is also associated with substance use, and quite recently in history really started with stimulant use. So let's get into that. Okay, agitated delirium, excited delirium syndrome. What is it? We're going to get into it shortly. Let's go briefly over what is delirium. Okay, delirium is something I'm quite familiar with as someone who spent most of my career in the hospital and mainly in the ER, ICU's floor. Let me start off by saying that delirium, it's quite important in that it is the most common neuropsychiatric syndrome or entity encountered by clinicians with elderly adults and the medically ill. Okay, you will usually see delirium in inpatient settings, in the ICU, and even in chronic care facilities, someone who's been down for quite some time. So usually the person is already quite ill and has extensive systemic, okay, or an isolated disease process occurring. Two, they're usually somewhat debilitated. And three, it's very common with the elderly. Okay, delirium is really best understood. It's got five kind of domains to it, the foundations of what is delirium, and one of them is cognition, right? There's a radical cognitive deficit. It's perceptual disturbances and distortions. There's memory issues, okay? Comprehension, abstract thinking. They can't focus, maintain, or retain attention, okay? There's difficulty with knowing time of day in terms of day and night, circadian rhythm disturbances, okay? There's a dysregulation there, okay? And the sleep cycle gets just completely destroyed. There can be emotional issues and dysregulation, okay? Sometimes there is anxiety, fear, sort of, they're perplexed by what's going on, who you are, where they're at, irritability, anger, and there's psychomotor dysregulation as well, okay? And, and psychomotor really refers to goal-directed fine motor movements in some senses, okay? And delirium itself, the way it declares itself, there's different types. There's the agitated, there's a sort of apathetic and withdrawn, there's a mixed type where they wax and wane, and the course of it all is waxing and waning. And you see this, and there's different terms for it, in the hospital. We call it in the ICU sundowning, right? Which means, the person has lost orientation of day and night, and they go into this delirious state. Now, like I said, it could take a few hours, few days. It comes on. It could, I believe, unlike what the DSM says, it could go on for quite a long time. But and it is associated with quite a bit of morbidity and potentially mortality. Even the fact, like, let's say if you're recovering from a hip surgery that went bad and there was an infection and you're in the ICU for a while, well, just the fact that you have to be down for a while really causes has a large impact on your recovery and functional status. That's what delirium is. It's something that you really shouldn't see out there too much. I'll give you one example. When an elderly would come in to the hospital, and we would just designate it as altered mental status, and they come in from a nursing home or care home, the first thing you look for is a urinary tract infection that has gone bad and worked its way up to the kidneys and the body, and they are in a state of delirium. So the causes are many, and I don't want to get too much into it, even though it's extremely interesting. I just want you to have an idea with delirium. How is that different than psychosis? Psychosis, and sometimes it could be hard to tell the difference, but with delirium, there's an absentee that is not the same that you see with psychosis. Or psychosis, it's very active and oriented, and the person suffering from psychosis appears to have a command of, remember, it's reality testing, so they believe they know something and they're adamant about it, and they believe that their beliefs they think are true, whereas with this there's an absentee of the patient, and you can usually delineate it from the history of the person. Okay, elderly, systemic disease, in the hospital or in the ICU for some time, it's more than likely that it's going to be delirium. Doesn't have to be the elderly, but that's it. So that's where the term delirium comes from. Now, let's get into what we really want to talk about. Excited, agitated delirium, excited delirium syndrome, agitated delirium syndrome, whatever. And that is where the kernel of all this is, so you can separate it from stimulant or methamphetamine psychosis or substance psychosis. Agitated or excited delirium, why is it important? Well, first of all, this stuff was first described as far back as 1800s, and I wish I can go into an historical account of this because it's really interesting. It was called, I believe, Bell's palsy, catatonic palsy or lethal catatonia, exhaustive mania, and all descriptions throughout time essentially describe the same thing. Okay, person started with delirium. Okay, and then there was quite a bit of agitation, and that agitation was quite extreme: fear, panic. Okay, violence, very extreme hyperactivity and psychomotor agitation, okay? Violence, potentially self-harm. And then there was a sudden stopping, a cessation of struggling, respiratory arrest, cardiac arrest, death, and all of that stuff, okay? And they all sort of describe the same thing, including really what should be called hyperthermia, very elevated temperature, including autonomic instability, okay? And that essentially means your fight or flight system, sympathetic and parasympathetic nervous system really almost collapse, okay? Because remember, those systems regulate your heart rate, blood pressure, your blood vessels, how open or closed they are. So there was this collapse of that. There was hyperthermia and death, okay? Now let's leave that, okay, and come up into the 1980s. Okay? And 1980s is when we first started seeing descriptions of excited delirium, agitated delirium, excited delirium syndrome, in the modern times in the literature. And a lot of this was associated with cocaine use, right? And people would show up across in this situation. But there's something more insidious about this issue here. This is actually a topic of discussion and an issue for people in custody, in police custody, in jails, and so forth. And oftentimes when you get this, and this has contributed to the controversy about police brutality and so on, these people die in custody, and nobody really understands why. It's sudden death. And it's really not fair to the law enforcement, whether other cases are true or not. It's not what I'm debating, but it tells me that there needs to be a lot of education across the board. So in the 80s, it started appearing in the literature as agitated delirium. It was sort of first associated with cocaine, okay? Agitated delirium, excited delirium, whatever you want to call it. This thing sort of, well, it was first described in the 1800s and had several names. Bell's mania, lethal catatonia, acute exhaustive mania throughout time. And it was always the same sort of sequence events and description. The person was in some sort of a state of delirium. It was followed by a high degree of agitation, psychomotor agitation, violent behavior, panic, shouting, violence, and they attempted to restrain the person, and then it was sudden respiratory arrest and death. Okay, so it's been around for a while. It presented itself, okay, in the last few decades, first in the literature in the 1980s, associated mainly with cocaine, methamphetamine, I believe some cases of ecstasy, and it was really sort of the same thing, okay? Bizarre, aggressive behavior, shouting, paranoia, panic, violence, and very, sort of, that PCP, unexpected physical strength that you see, okay? And hyperthermia, okay, which is elevated body temperature. That's important, okay? That's when it first presented itself. And then we saw it again with flocka, okay, around 2007, 8, 9, 10, 11, okay? And why is this important? Apparently, well, there is about an 8 to 10% of mortality associated with death, okay? Just like we described just a second ago in the historical account of this. So, I think of it as a few features, okay? Okay, so the other important thing with this is that this has worked its way into the discussion with police custody and the literature surrounding that, because you also see it in cases of police custody or any sort of custody, and obviously it's ubiquitous in my traditional field of emergency medicine. In fact, I've dealt with this many times, and I'm going to close this with an example of this, where someone is brought in just in a highly agitated state. It's important in the discussion of in the social sciences of people being in police custody and so forth, because these people are being restrained and then there's sudden death, okay? And then this really fuels controversy and the issue of police brutality, which I'm not denying, but this certainly wouldn't be fair, because it's the issue of excited delirium versus something else, okay? And it's also important because in the emergency departments all across the United States and Europe, this is encountered. Three things about it that I think of that are critical for me. It's the autonomic instability and collapse, which really affects your heart rate, your blood pressure, your system to be able to physically maintain its needs. The hyperthermia, elevated temperature, right? And uncontrollable behavior, right? Those two things, the first two things themselves, are huge red flags for any hospital physician, okay? So it's got these features, and it first declared itself with cocaine and other stimulants and really made headway in what flocka and synthetic cathinones, which we discussed, and what happened in Florida. So that is what agitated and excited delirium is. Its mechanism still has to a great extent be elucidated. Obviously, there's probably a big surge of dopamine. The management is also with this, whether it's law enforcement, first responders, medical personnel, okay? And what can I tell you about it other than the fact that it is a separate entity than psychosis, okay? And it has a very high risk of death and needs to be managed appropriately. And it is associated with stimulants, cocaine, methamphetamines, bath salts, in particular flocka. And there's quite a bit of discussion and discovery about who's more at risk for it. More importantly, I want you to be aware of this, and it's a different entity than methamphetamine psychosis, associated with the same type of drugs. and it can have really bad outcomes, okay? And that is excited delirium syndrome. I'm going to tell you about a very important, very interesting case for you. And it sort of puts all of this into perspective, I hope, and gives you some insight into what you have to deal with as a clinician. I was quite young clinician working at the University Hospital, Central Valley of California, where there's a lot of meth. I believe I was a senior resident, and I was working with a great attending physician who was very well known in my field and was actually near retirement. This guy was just cool as a cat. And it was about, I don't know, it was quite late at night, 2 in the morning, usual Saturday night. I believe I was the senior on, and trying to manage this crazy department. There's, the psychiatry emergency section. There's kids crying. There's prisoners being brought in for clearance, guys drunk, hungover, beat up, medical issues. And I hear a call, and they're bringing in someone. And this is important. You get, as a clinician, you kind of hone in. And, they were saying meth psychosis. Okay. Now, keep in mind, it was about 45 degrees out. And this guy was coming from somewhere out in the boonies, in the mountains in Central California. And next thing I see is 3, 4, 5 enforcement officers and first responders walking in this guy that was about 6'2", completely naked from head to toe. And the report I got, all you know about the patient. Remember, I told you the history is critical for you to be able to sort things out. All I knew about this man was that he was found out in the mountains just banging on people's doors at the Motel 6, running around butt naked. So we take him into the trauma bay, and I always approach a patient with the idea of do least harm. Everything you do can cause harm, okay? I thought it was methamphetamines. I just need to get, immediately my mind goes, okay, meth psychosis or maybe some PCP. I need to hold them down just enough to get an intravenous line in and push a whole bunch of benzodiazepines. Then I'm good, and he's sedated, and I can manage the situation. That was my thinking. And in that endeavor, I spent the next 10 minutes. Basically, I just climbed on the gurney, sat on his chest, while 6 or 7 big law enforcement guys and nurses were holding this guy down barely. And the nurse was trying to put a line in him, and I was sitting on top of him without hurting him, but really trying to do an exam and see if there was any cognition, alertness, awareness, and so on. Eventually, an attending faculty came up to me in my ear and said, I understand what you're trying to do, but keep this in mind. I understand you're trying to minimize impact on the patient, but keep this in mind. You got 6 or 7 big dudes around here sweating. You're putting everyone else's life in danger. At some point, you got to make a decision, pull the trigger. I did. And I went ahead and pushed a couple of drugs real quick and got this guy intubated so I can proceed with my exam, medical management and laboratory evaluation. He went down, and I recall, his heart rate was a little bit high, his blood pressure was high, expected, and so forth. And I intubated him pretty easily, and he was sedated and started running some fluid. And my expectation is keep him down until he starts, the medication I give wears off, and he starts, unless you send labs and urine and so forth, okay? So I feel pretty cool, right? Like I know what the hell I'm doing. And wow, this was a big guy, and I was able to control him without anyone or him getting hurt, get the intravenous line in. It's probably methamphetamine psychosis, because I see some of this stuff, or some PCP in there, or you smoke some spice, whatever it is, or bath salts. And I have seen cases of agitated delirium. But, when I looked at his vitals, this temperature, I'll never forget, was 97.8. If it's too high, you're worried about something. If it's too low, you're kind of worried about the same set of things. So about an hour passes, and the great attending I was telling you guys about comes back into the office and says, hey, Bonnie Mark, come here. And very cool as a cat. He just walks me over to this guy's gurney where he's intubated, grabs the guy's neck and does pulls it up and says, if you're ever wondering, this is called natural rigidity, and it's a test for meningitis. And here's a guy that's out, and it was stiff as a cardboard. And he just kind of looked at me and said, you better get a lumbar puncture. So I was like, oh crap. And I looked at his temperature. At that moment, it started registering. It's 43 degrees out and he's butt naked. Who knows where his regulation was being reset at. Send a lumbar puncture, and this guy had severe meningitis. The laboratory, hey, come down here and check this out. I looked through the microscope. I've never seen so many bacteria invaded. I ran back up. His labs were coming back. He had very obvious evidence of infection on the labs. And immediately I started the broad spectrum and the appropriate antibiotics for him. And he expired 3 or 4 hours later, sadly. Now, this could have been a major goof up. And I'll tell you why. Because in that scenario, you are supposed to immediately pull the trigger and start antibiotics, okay? The thing with him was that his body was so overtaken by bacteria that even my half-hour delay in starting antibiotics didn't matter, but I could have missed a very major thing there. And on your differential, you know, it has to be broad what you're thinking, all right? And so here's a case where psychosis, maybe agitated delirium. Okay, I'm going to manage him. It wasn't even that. It was due to an infectious process. Okay, I hope you enjoyed this video. It was a little bit long. I think it was informative. We have other videos in the series coming up and in the past regarding these issues. If you did like this, please go ahead, press the like, subscribe, the notification bell. And if you're so inclined, please go ahead and contribute to our Patreon account. Have a wonderful day and see you guys soon.